So hello everyone. We welcome all aspirants who are preparing for Neet SS 2022 for our general surgery section. Today, Dr. Ashwini ma'am will take the class on trauma 1 and transplant. But today the trauma 1 and trauma 2. It's almost 4-hour class, including both sessions. So she's had very good feedback from last classes, and she's very good in the teaching. So hope you people enjoy. Welcome Ashwini ma'am. We from last year we have for feedback from a student. Your class were awesome. So please continue on the platform. Thank you for being with us.
Thank you, sir. Thank you for the opportunity, and congratulations once again for the massive results produced last year in a shorter span of time, and also for the changed pattern all of a sudden. I congratulate all the winners as well as Dr. Vipin sir for his exclusive efforts.
Thank you, ma'am. Thank you. It's not a mine alone efforts. It's your team effort basically.
Sure, sir. Sure, sir. Thank
Can you start your video also? It will be good if you possible. Otherwise, no problem.
Sir, I'm in very bad shape. I will start it for the next session, sir, because
sure.
I'm with the baby all alone since morning.
No problem.
And I'll start in the next session. Sorry.
No issue, ma'am. Yeah, thank you. Thank you.
Thank you. So moving on to trauma. Kindly let me know if I'm not audible or if my internet connection is slow at any point of time. So we'll be dealing with these topics: introduction to trauma and scoring systems, triage, assessment and management, pediatric trauma considerations, specific injuries, lastly about the disaster and conflict surgeries. So introduction to trauma. What is major trauma? Major trauma means more than one body region and one organ system is injured. So that defines major trauma. So in Bailey, it is given, I have combined both Bailey and subsequent recent updates, which are all the high yield areas or whichever possible questions can be raised. I have marked in red. So if any questions you can ask in the chat box, I'll clarify. So in the young, injuries are due to RTA maximum by the high energy transfer, whereas in old patients, most trauma occurs due to trivial falls also. So in old patients, already the vessels will be lax and they will be having some comorbidities. So even low energy transfer can cause a significant impact in the old individuals. So timeline concept, this is given in Bailey. So the time required for overall time required for the death is given above, whereas before that we should intervene. So before half of the time we should intervene and do the assessment, and remaining time should be utilized for response. If not happening, it will lead to ultimate death of the patient. So this is very important. So we'll be dealing with the assessment of trauma, clinical examination, everything. But the assessment always, you should think in mind the formula. This is given in Bailey, can be asked as a 1 mark in MCQ. The injury equals mechanism of injury plus the patient factors. So if at all, you will be dealing with each of the 3 in the following session. So if these 2 don't add up to the injury, and if there is some discrepancy, you should always look out for the hidden factors or less obvious factors. So overall trauma, blunt mechanism is the most common cause of most of the trauma, and blunt may be either direct or indirect. And the less common injury is penetrating injury. In penetrating injury, it can be either sharp objects or firearms. So the sharp objects depends upon the length of the object only, whereas in firearms, there will be both temporary and permanent cavity, which we'll be dealing in detail. So as I said, the pattern of injury, will be dealing with the mechanism of injury first. So if at all there is a lap belt injury, so the lap belt injury can cause chance fracture of the lumbar spine, dislocated knee. So these are all the obvious features or the direct impact, whereas the indirect impact, because of the fractured lumbar spine or because of the shearing force, the duodenum can get ruptured. So this should be running at the back of our minds before we embark on the management of lumbar spine fracture alone. So this should be ruled out. Only if we bear this in mind, we'll be able to rule it out in a severely injured individual. So based on the mechanism, you should suspect some covert injuries or hidden injuries and do the appropriate investigation. If not, it will be missed easily. So for example, dislocated knee, the impact would be transmitted to the popliteal artery and disrupting the popliteal artery, totally causing hemorrhage. Same way, electrocution, there will be a small wound on the burnt wound on the hand and the patient may have collapsed. But easily missing injury is the posterior dislocation of the shoulder. So these things are very important because covert injuries should be always looked out. And the introduction to trauma, as I told, the hidden factors should be oriented towards the patient, mechanism, as well as the injury. So what are the mechanisms of injury? Hidden mechanism, always look out for non-accidental injury. That is, in a child, it may be because of child abuse also. So those injuries come under non-accidental injuries. So what are the factors suspicious of non-accidental injury? There will be external signs of injury inconsistent with the mechanism reported. So the mechanism of injury will be different, the history will be different. So there will be some discrepancy with the history and the effect. So that case we have to think about in non-accidental injury. And there are long bone fractures in a pre-ambulatory child. So the child may not even started walking. But if the child is having long bone fractures, then you should suspect non-accidental mode of injury. Or as I told, there will be consistently changing history from the parents or unusual behavior of the caregivers at the time of history taking. And most important, posterior rib injuries. Please note it down. Posterior rib fractures because of continuous slapping of the child or continuous beating of the child. Those can give rise to suspicion of non-accidental injuries. So as I told, we have dealt with the hidden mechanism, hidden history taking, hidden patient factors. Now going to the hidden injury. So what are the injuries that can be missed easily? Those come under specific injuries missed on a regular basis. So there are certain type of injuries which are missed on a regular basis. Example, fracture metacarpal, metatarsal, scaphoid, lunate, posterior dislocation of the shoulder, or rotator cuff tears. So these injuries we won't even be thinking of, but they will be missed on a regular basis. The only problem here is these injuries can lead on to long-term disability for the patient. So it has to be screened. That is called as focused exclusion approach. So we have to look out for certain specific injuries on a regular basis. So another approach is look everywhere approach given in Bailey. You should always have a low threshold for whole body CT. Because even though the whole body CT carries 76, equivalent to 76 chest X-rays or 6 months of background radiation, there is every chance we can miss certain injuries. So you have to always have a low threshold for whole body CT in a severely injured individuals, not for all patients. So that comes under look everywhere approach or focused exclusion approach. So this all comes under the patient, mechanism, and injury. Going on to the response to the trauma. So a trauma has happened. How does a patient respond? How as doctors we are going to respond? So the patient responses that require prompt attention. What are the responses that require prompt attention? You remember is that top: temperature, oxygenation, perfusion. These three will be massively disrupted in a diseased or severely traumatic patient. So once this hypothermia, hypoxia, and acidosis happens, it becomes a vicious cycle, which has to be deliberately prevented. So that comes under patient response. What about medical response? That is what we are going to deal in detail. Advanced trauma life support and damage control surgery. So what is damage control surgery and what is early total care? That difference we'll be seeing now. So early total care, doing the definitive treatment for whatever cause it may be. For if it is a ruptured abdominal organ or if it is a fracture case, if you are able to do the definitive surgery within 36 hours of injury, it is called as early total care. I repeat, whatever the mode of injury, whatever the diagnosis, if you are able to do the definitive repair. That is, if the fracture, if you are able to give an internal fixation, or if there's a perforation, you are able to do the definitive repair of the perforation within 36 hours of injury. That becomes early total care. So what is DCS? You are not able to give the early total care in select individuals. So what are the type of individuals and what are the circumstances where you won't be able to deliver early total care is the patient is having severe hypothermia, acidosis, lactic acidosis, that is lactate levels more than 5, severe coagulopathy, patient is in shock and you have almost transfused more than 15 units of blood and injury severity score is more than 36. So this comes under the physiological parameters, that is hypothermia, lactic acidosis, coagulopathy, hypoxia, and injury severity score more than 36. All these are indications, clear-cut indications of DCS. So what are the physiological and anatomical indications? Anatomical indications, you opened the abdomen or you have started some surgery, but you are not able to achieve the correct hemostasis. So that comes under the anatomical indication. And what about complex abdominal injury, complex vascular injury, and you're not able to access any major venous injury? So these come under indications for DCS in an anatomical setting. So in the operation theater, what are the indications? If you are doing a procedure more than 1 hour in a physiologically unstable patient, because as the operating time increases, the temperature loss is going to happen 2 degrees Celsius every 1 hour. You want to cut down on that. So you are going to embark on damage control surgery. And you are not able to include the abdominal incision or close it properly. Or if you deliberately want to take a relook at the intra-abdominal contents, then you have to go for a damage control surgery. So anatomical, physiological parameters and the operating time, the operation theater factors. So this can be asked in MCQ, very important slide. So there are 5 stages of damage control surgery. Any damage control surgery for any purpose you are doing, it consists of 5 stages. First stage, immediately select the patient and immediately resuscitate. That is called as primary resuscitation. So quickly, maximum half an hour, you have to resuscitate the patient as much as possible with minimal crystalloids or blood products. Shashwat Singh wants the previous slide to be repeated. So this is taken from Bailey. There are 3 types of indications for DCS. Damage control surgery is where you want to just control that is the patient is physiologically unstable. You don't want to do definitive repair at this time. You just want to make sure the patient is alive, but you want to control the infection and control the hemorrhage. 2 main aims of DCS. I repeat, control the infection, control the hemorrhage. So to achieve this, you should cut down on the procedure time. You should do what is needed, the minimum needed, whatever can be done, you should do it. And you should come out of the operation theater as quick as possible. So what are those indications as been listed here? The physiological indications are hypothermia, acidosis, lactate more than 5, blood pressure less than 70, transfusion almost more than 15 units. An injury severity score, which we'll be dealing with now in injury scoring systems. That time I will be explaining it, more than 36. You just remember it as of now. The anatomical indicators is you have opened the abdomen or you have started some surgery, but you are not able to achieve complete hemostasis. Or the procedure is very complex. The injury of the organ injured is very complex. For example, liver, pancreas, or there is severe vascular injury, which you are not able to salvage. So just control or clamp, whatever can be done, the minimum you do and come out. So that is what is the indication. And physiological indicators, extra is coagulation time. As I told, the patient will go in for coagulopathy easily. So if you suspect the patient is in coagulopathy, it is an indication for damage control. And as I told, in the operation theater, if your operating time is proceeding beyond 1 hour, patient will go in for progressive hypothermia. Hypothermia once again leading to acidosis and coagulopathy. So you don't want that vicious cycle to start. So you want to convert it into damage control. And you're not able to close the abdominal incision in the first shot itself. So you better do a temporary closure of the abdomen and come back after 48 hours. You can then close the abdomen permanently. And if you want to, for example, if there is mesenteric ischemia, you have resected the bowel and you want to give a second look to know whether the bowel is safe or it wants a revision. So that time you can do a temporary closure of the abdomen. So all this comes under BCS. Is it clear, doctor? Okay, we'll proceed. So 5 stages of BCS. The stage 1, patient selection after primary resuscitation. That is, you have to, as based on the previous slides, you have to do a patient selection very, very carefully. So based on that, you have to do a primary resuscitation. Resuscitation should be taking place in the operation theater as much as possible, taken from daily. Don't do any primary. If you have decided you are going to shift the patient to OT, shift the patient as early as possible to the operation theater and start primary resuscitation with crystalloids, or much better with blood products in the operation theater itself. So much of the resuscitation should happen in the operation theater for stage 1. All right, once you have somewhat picked up the BP to 90, say systolic 90, 60 like that, you can then proceed with stage 2, that is damage control surgery. As I told, 2 objectives, 2 main aims: control of hemorrhage, control of infection. So contamination should be controlled, active hemorrhage should be controlled. That's all. No other aim of restoring the anatomical continuity, nothing. Just control infection, control hemorrhage. After it is done, if you are able to close the abdomen, fine. If you are not able to do, just temporarily close or just put the adhesive tapes and come out, transfer the patient to ICU. So the second part of resuscitation takes place here. What is the second part of resuscitation? It is called as balanced resuscitation. So what are the components of balanced resuscitation? Please see below. You are going to allow some sort of hypotension, permissive hypotension. So you are going to allow hypotension to prevent hemorrhage and minimize as much as crystalloids as possible, because crystalloids is not going to be of any use in a case of active bleeding. And as much as possible, immediately administer blood products, that is Paxil, FFP, cryoprecipitate platelet. This is from Sebastian in the ratio 1:1:1 as much as possible. So this 1:1:1 almost mimics the natural blood of the patient itself. So this you have to administer. These form the components of balanced resuscitation. Stage 4, once after resuscitation is complete, look out for all those parameters again. These parameters, the temperature levels, pH level, lactate level, everything. And then if the patient, see here, this table is important. So if the patient is having if the patient is having more than 5, completely DCS only. If the patient is less than 2 lactate levels, early total care can be taken up. If it is 2 to 3, look at the trend whether it is increasing or decreasing. If it is more than 3, either continue resuscitation or just proceed with damage control only. So once the lactate levels are improved, then you can go on to stage 5. Stage 4 and stage 5 only after the physiological parameters have been improved. So I repeat this slide quickly since it is very important. Stage 1 is called primary resuscitation. Don't do it in the emergency room. Do it only in the operation theater as much as possible. After a quick resuscitation, take up the patient for surgery. Do a control of hemorrhage and active infection. Once it is controlled, shift the patient to ICU. What we do there is called balanced resuscitation. And I forgot to mention one more thing. This resuscitation, that is stage 1 primary resuscitation and stage 3 balanced resuscitation, is together they are called as damage control resuscitation, DCR. So damage control resuscitation combines both stage 1 as well as stage 3 resuscitation. Damage control surgery comprises of all the 5 stages. So don't get confused. And after these 3 stages are done, if the patient is physiologically stable, his parameters have been improved, then once again shift the patient to OT, do the definitive repair, and lastly perform an abdominal closure. Am I clear? So continuing. So this is an example of temporary wound closure using offsite sandwich or backpack. So this diagram is taken from Bailey only. So the outer layer is off-site, inner layer is off-site. Inner layer will be closely adherent to the bowel loops, whereas the outer layer will be adherent to the skin. And in between, there will be a suction drain. In between these two layers, there will be a suction drain, which provides efficient suction to suck out all the toxic fluid until the abdomen is fit for a permanent closure. Okay. So as this slide I have already mentioned, so response to resuscitation, you have to elicit with the following criteria: heart rate, urine output, ABG, coagulation profile. There should be no hypothermia, all this. And total lactate level more than 5, go for DCS, less than 2, go for early total care. In between, you have to decide whether the trend is increasing or decreasing. Based on that, you have to decide, take up a decision. So less than 2, more than 5. Please keep these two in mind. So patient with massive hemorrhage presents to the emergency room after RTA. Which of the following should not be done? Answers, please.
IV crystalloid.
D. Check coagulation with thromboelastography.
No, that can be done, but hemorrhage 2 liters of crystalloids.
1 liter is given.
Yeah, only 1 liter. So that is the answer. Maximum 250 ml. 250 ml in suggestion it has been given. 250 ml boluses can be given. Short boluses also. Not exceeding 2 bolus of 250 ml. That is maximum of 500 ml only has to be given. Only to buy time to arrive. That is to arrange for the blood products. So no other role for crystalloids. Not to resuscitate the patient. Nothing. So the answer is IV crystalloid 2 liters is totally unwarranted, because massive hemorrhage, only there is role for blood and blood products. So as I told, we are going to deal with the trauma scoring systems. So anatomical, physiological, combined injury severity. Based on these 4, the trauma scoring systems can be divided. So what is anatomical? Based on the just anatomy of the organs or anatomy of the head to foot organs, regions. So both these come under anatomical. Physiological, they form the GCS, RTS, both form the physiological indices. Combined trauma injury severity score and injury severity only based on the severity alone. Here comes the post-dot code, ISS, TRIS, everything along with MES. So based on these 4 categories, we can divide the trauma severity index. So what is AIS, abbreviated injury score? It is comprising of almost more than 2000 injury codes. It is taken from Sebastian. So it is a 6-digit taxonomy where the first digit represents the body region only. For example, 1 represents head. So based on that, like that, several regions will be given 1 code. So what about the severity code? As I mentioned here, AIS severity code or post-dot code. It's nothing but it forms the 7th digit of abbreviated injury score itself. The 7th digit only indicates the severity and risk of death. So I'm just repeating it since it is slightly confusing. Abbreviated injury score is purely a anatomical score where it is a 6-digit taxonomy and the first digit represents the body region. Whereas if you add a 7th digit to the same, that 7th digit represents the AIS severity code or the post-dot code. This indicates the severity and risk of death. So that is why it comes under severity score. So what is injury severity score? It is once again, this AIS forms the basis for calculation of most of the other scores as well. So injury severity score, this is nothing but sum of square of 3 most injured regions in AIS. So sum of square, that is sum of square of 3 most injured regions in AIS forms the ISS. So this only I told in DCS. Do you remember this slide? So injury severity score more than 36, it is a clear-cut indication for DCS because you can't do a definitive repair with such a severe injury. So more than 15, it is called as major trauma. More than 35, it is a clear-cut indication for DCS. Next slide. Trauma scoring systems. Here comes the physiological. So physiological, there are two scores, GCS as well as revised trauma score. GCS, we all know, will be dealing it with the head injury, and revised trauma score, and the range you have to remember. That is why I have highlighted it. GCS score ranges from 3 to 15, whereas revised trauma score ranges from 0 to 12. Revised trauma score, it is based on 3 criteria: GCS, systolic BP, and respiratory rate. So it ranges from 0 to 12, GCS 3 to 15. So what is TRIS? Trauma Injury Severity Score combines both the injury severity score, RTS, age, as well as mechanism of injury. Based on these 4 factors, the TRIS score will be calculated. And MES scoring, it is predominantly useful in orthopedic injuries only, not in general surgery. So it calculates the, it predicts whether there is a need for amputation or not. So mangled extremity severity score, it combines the energy that caused injury, the limb ischemia grade, whether it is severe or mild, presence or absence of shock in the patient, age of the patient. All these criteria are put together, they form the MES scoring. The mnemonic here is ELISA. So the MES score more than 7, there is a typical need for amputation. So ISS score ranges from injury severity score
1 to 75.
Okay. So going on to triage. So I am completing all these short topics together first, so that we'll deal with chest, abdomen, and other abdominal trauma in detail in the second session of the presentation. So going on to triage, it is derived from French verb trier, meaning to sort out. So it forms the cornerstone of management of most of the mass casualties. So why triaging is important? It's because most of the mass casualties, only 10 to 15% of the casualties are serious enough to require hospitalization. So unnecessarily admitting all the patients can give a big hit to the hospital resources, depriving the really needed patients of the efficient resources that are possible. So all methods of triage use simple criteria just based on the physiological signs, pulse rate, BP for the rapid clinical assessment. So what is the aim? You have to do the most good for most patients with available resources only. So, but please remember, it is not a one-time event. You have to keep re-triaging as often as possible, because some patients can deteriorate. You can label the patient as green initially, but the patient may have progressed to the yellow category in a while. In 2 hours or so, the patient may have progressed to the yellow category. So one-time triage is not the rule. Re-triaging is always indicated. So the color codes, important slide, can be asked, anything can be asked. Given options as which category does it belong to? Red, yellow, green, or black. So first I'll complete black. Black is total, that is, it is totally unsalvageable, no breathing, no nothing. So you are not going to offer any medical help to these patients. So what are the types? Extensive burns, more than 90%. You're not able to do anything. Unnecessarily, you can't waste the resources on such patients who are imminently to die, or there is major loss of chest or abdominal wall structures. So those cases come under black category. What about yellow? Yellow is very important because all the pelvic fractures, spinal injuries, compound fractures, holoviscous perforation, all these are urgent only, but they will be likely to survive if treatment is given within hours. Just within few hours, you have to start the patient. So those examples come under yellow category. Whereas red, medical need is very, very immediate. Patient is extremely critical. As much as early as possible, you have to start the treatment. So you remember this category as 2 types. Those diagnoses that require immediate intubation, or those that require immediate evacuation. I repeat, immediate intubation or immediate evacuation. So immediate intubation, just remember severe facial trauma, flail chest with severe hypoxia, all these indicate immediate intubation. Whereas immediate evacuation, hemothorax, pneumothorax, profuse extradural hematoma, all these need immediate evacuation. If not evacuated immediately, patient will die. So that is why I told us immediate intubation or immediate evacuation. So these come under red category. Yellow category, all the fractures, all the ruptured viscous, all viscous perforation, spinal injuries, all come under the yellow category. Green, you can remember, it is nothing to remember. Non-urgent, you can even delay the treatment up to hours to days. So there is nothing to remember there. So only red you have to remember. Green, you can mention it. Yellow, those which does not come under red, green, or black. So you can remember this that way. So code yellow includes all except
EDI.